Hi, everybody, and welcome to the Hanley Effect. I'm John Dyben.
I'm Rachel Docekal.
How are you, Dr. Docekal?
Good, Dr. D. How are you?
I am lovely. So, we have had, both of us have been in this field doing this work for a long time.
Since
And
we're very young.
that's right. And we're only 30 now,
Yes,
so
we're-
it's been. But, one of the things that, you start to see patterns, right? So people have, this experience and that experience, and it almost becomes predictable. But one of the things that I'll tell you in, 21 years plus of being at Hanley and more than 25 years of being an addiction therapist, is that benzodiazepines are they are a really interesting class of drugs.
They are.
And they are one that I have seen more, they've baffled me. People's responses have baffled me more than anything. And so I really am excited today to talk about benzodiazepines and to talk about somebody's personal story. So we ready to just jump into it?
Jump in.
Or shall I blather on some more?
I love your blather.
Well, I
but
appreciate
let's jump in.
But I'm excited. We have D.E. Foster. D, you are here from calling in from Colorado. We thank you for your time and want to welcome you.
Thank you so much. It's such a pleasure to be here. I was just mentioning ahead of time, I have really been looking forward to this one. Before I do podcasts, I always research and listen to the episodes. And the more I listen to you two and the people that were on, and then research the foundation and the center, the more and more I got really excited to do this conversation, because the work that you all have been doing through the Hanley Foundation is just incredible. And I just want to say kudos for all the work that you guys have done in the world of addiction and everything else. So
thank you so much.
It's a pleasure to be here.
And I also, right, I get to stalk everybody before we meet them if I don't know them. And I got really interested. So I'm looking at some of the things that you've accomplished, like co-authoring academic papers on something called Bind. And I want you to explain that. And not only that, but co-authoring and being on a panel with the American Society of Addiction Medicine. And I'm like, okay, so who is this physician? And what I find is this is an educated guy, but his education and background isn't in medicine. It's in media and communication. And there's a whole different reason why you have been so instrumental in helping the scientific and medical community. So I want to be quiet and I want to ask you to tell us about who you are, what kinds of things you're doing now, but most importantly, and as if you've watched this podcast, that we really love to get to know as much of your story and what brought you here as you're willing to share.
Thank you. I appreciate the introduction. Thank you so much. If you looked at me 15 years ago, I was a database developer, and I also had a secondary occupation of screenwriting. I worked with film festivals around the nation. So 2 different occupations going on for about 25 years. Long story short, I took Klonopin, a benzodiazepine, for 12 years as prescribed by my physician. Had no idea there was any dangers, any complications with it. I later found out I was dependent on the drug. I tapered off of it 18 months. I am now 11 years benzo free, but I still have this, what we call protracted symptomatology, or bind, as you mentioned. That still affects my life. I'm doing great compared to where I was, but this is still carries with me for a long time. Through that, I wasn't able to work in IT anymore and do most of the things I could do because of anxiety, because of my symptoms and everything. I wrote a book, published that in 2018, called Benzo Free, The World of Anti-Anxiety Drugs and the Reality of Withdrawal. I have to look up to remember the whole title of my book.
I relate.
That. Yeah. So I published that, and I became active in what I call the Benzo community, which is an online group of just incredible people who, most of us are lived experience. We've been harmed by benzos, and we are trying to help other people who are going through it. We're trying to raise awareness, educate, and there are amazing organizations out there. So I started forming my own organizations, and I formed a website. I started a podcast in 2019 called the Benzo Free Podcast. I have a second podcast now called Uneven Podcast. And then I just launched a community online called Uneven Life, at unevenlife.com. And it's actually where we provide direct support. We do daily sessions with individuals who are dealing with anxiety and or the complications of anxiety medication, such as benzodiazepines and Z drugs. And we work with them directly. And through all that, I got involved in a lot of different organizations and I got pulled into research, like you mentioned. And so I now have 10 total papers that co-authored, 7 are studies. And I worked with a group out of Ireland on a couple papers. I work with a group out of the Alliance for Benzodiazepine Best Practices. And we did a study, and that was over 3 different papers. And the last paper of that was the Bind paper. And that one's where we discovered actually this protracted symptomatology and why it's different than withdrawal or acute withdrawal. And it's this element of physical dependence. And I just want to say one thing to you all, especially on the Hanley Center, was I'm always looking at rehab facilities because we've had some, come and go. Sometimes they're good with benzo, sometimes they're not so good. I work with a lot of people who had a bad experience in rehab. And I went to your site, and of course I saw benzodiazepines, and I clicked on it, and I looked down, and I want to say thank you. You not only mentioned addiction, but you have a whole section on physical dependence. And that right away told me you understand this to some degree, you're on board, and I would love to, find a way to work more and help, increase that and that kind of thing. But I was just really impressed to see that listed on your page for your treatment centers. So
So
I just
for
wanted to throw that out there.
Thank you. And for somebody who's listening to this and who says, well, what's the difference? Physical dependence. If you're dependent on the drug, that means
Yeah.
you're addicted. It's all the same stuff. What do you see? How would you describe to someone the difference between physical dependence or physiological dependence and addiction?
Boy, I present that all the time. That's a great question. That's probably our most common thing. We created a whole peer development training course, a 12-hour course, and a whole section is on dependence versus addiction, or SUD, depending on, who you're speaking to at the time. The basic difference is addiction is what we expect withdrawal to be coming off these drugs for most drugs. You're talking opioids, sometimes the antipsychotics, sometimes the antidepressants, also sometimes benzodiazepines. There is addiction. And I want to make it clear, there is addiction with benzodiazepines. People can become addicted to benzodiazepines. We know that. The problem is that we have found the vast majority of people who have difficulty are not addicted, and they're dealing with physical dependence. Physical dependence is when the drug you're taking stops actually having the same effect for the condition you are taking it for. You're reaching tolerance, okay? And so then your body starts to adapt to it. And we identify the physical dependence, especially what we call bind. We identify that by looking at the actual physical symptoms that are coming on. Most withdrawal, it's the original condition that comes back, and often comes back really strong. With bind and with other things we're seeing protracted, what we see is these new symptoms, what we call in research as de novo symptoms. And these are new symptoms this patient never had before they took this drug. And they can come along, people get 5, 10, 15, 20 different symptoms. I had over 50 different neurological symptoms coming off these drugs. They rotate around, and we're seeing that difference. So physical dependence is you become dependent on the drug. And it takes sometimes much longer once you remove the drug from the body for us to reset our nervous system.
And
I don't
then
know if that makes sense. That's kind of how that's the
it-
best description I could do right now.
it makes total sense because addiction then is physiological dependence is often a big part of that addiction,
Right,
but addiction
right.
is that change in the brain that then causes compulsive use
Exactly.
despite harm. And so it literally puts the brain into a survival state. So the way a physician friend of mine describes it, he'd been a surgeon, and he said, I'll do a procedure, and my folks are recovering in the hospital, and they're going to be on opiates for post-operative pain, and sometimes they'll become dependent on them. And some patients will say, this is the worst feeling in the world as they're coming off of it. They're experiencing withdrawal. They'll say, don't ever put me on this drug again. That's someone who's become dependent, but without the brain change of addiction. Patient next door will say, this is terrible. I need more and more and more and more. And
that's exactly it.
That's
exactly
the
what you said is the craving and the
Yes.
compulsivity, as you mentioned, is more the addiction.
and it's
Most
not
of the people I work with don't have that. Most of the people I work with don't have the compulsivity. They don't have the craving for the drug. They have the effects of the symptoms from coming off the drug, but that's separate from having this compulsion to take the medication. They take the medication because they're afraid of these symptoms they're
that's right.
experiencing coming off. Yeah,
Both are medical conditions. The key I want to make sure that we say
absolutely.
both, neither
Yeah.
one is about being strong or weak or smart or
Yes.
good or bad. They are both just medical conditions.
That actually was the point that I was going to make.
Yes.
That, and people, at least at Hanley, talk about being terrified when these new symptoms pop up. And
Hmm.
many times we see this type of use with our older adult patients. And, that makes it even harder because there are a lot of drugs that folks come in using, most of which they're dependent on. Some
Hmm.
of them, blood pressure meds, things like that, they really need.
Right.
And the additional symptoms that you're talking about are just terrifying.
They are incredibly terrifying. In fact, fear and the anxiety tied with that fear is the number one thing we deal with our patients. And also, and it makes sense, there's a physiological response system that goes on, and I can always explain that, that actually causes that. One of the things that I got, you mentioned like the stigma, and that's one thing I want to make sure I also mention, because I had the pleasure of, through grassroots, we co-founded an organization called Benzodiazepine Action Work Group, and it was part of the Colorado Consortium for Prescription Drug Abuse Prevention. So by being absorbed by them and being one of their work groups that I co-chaired with a doctor from University of Colorado, um, I got to see the opioid world, and I
Mm.
got to see the
Oh,
world of addiction and SUD, and I wasn't as familiar with that. So for 3 years co-chairing that, it was the best education for me because I got to see, hey, what we're going through is dependence, not addiction. Don't call us addicts. It's like, wait a minute, calling addicts as part of the problem in the first place because we're stigmatizing. And that really helped to educate me and help me understand that, like, just as you said, these are both medical conditions and both have to be dealt with respect, with destigmatizing language. So we understand what the people are experiencing. And that's the one thing I want to make sure I emphasize. It's not that I'm differentiating it because I'm saying this is, that's addiction, this is that. I'm saying this is a different condition that needs a different approach,
Right.
okay, than we've done typically with SUD.
just for our listeners,
Mhm,
SUD is substance use disorder.
Hmm.
Um, y- y- you know, John, I want you to as always give your medical definition of addiction because this is really important.
Well, so addiction is, people. We all have a relationship with mood altering substances,
Mhm.
whether it's recreational or legal or illegal, right? Either we're abstinent or we use and doesn't cause any problems. Most Americans, by the way, use their medicines and have a glass of wine or something and use
yeah,
and have no problems. But some people develop problems with it, and then some people, though, all of these categories they're volitional, they can change. And even someone like you're describing, like this is, it stinks, it's got these terrible problems and I've got these anxiety and I've got, but when I haven't crossed the line into addiction, I have my ability to choose. Once I cross over into addiction, the difference there is that the brain changes into a survival state. And it's sort of like, yeah, I tell people, my dad's the most moral, smart, tough guy you ever want to meet. And he's a scientist and he was a fighter pilot. And he was, and he talked about, being in survival school and having to go this long, long period of time without water. And he said, what I learned about myself is at some point where I'm dying of
mhm,
thirst, I'll do anything to get water. I'll lie, cheat, steal. And it's not about being weak. It's about
it's
that
not
change in
exactly.
the brain. And
Yeah,
but I think that the point though is that they are different conditions. They are different diseases. And so treating them differently.
exactly.
And I wanna in a second, I wanna ask you about what that treatment looks like from your perspective, but I'm really interested. So when we talk about benzodiazepine-induced neurological disorders. When you're talking about bind, we have not yet said those words. I thank you for letting me be the first because I just
And you're really close. It's dysfunction.
Oh,
dysfunction.
I know
dysfunction.
we
Dysfunction.
actually considered making it disorder. So I'll tell you, you were really close but we wound up with dysfunction when we decided
and
to
that
determine.
that makes sense. So
Okay.
when I talk a lot about addiction and things, and when I talk to people, we talk about acute withdrawal, and most people know, if someone becomes addicted to a drug or even dependent on it, right? For what they have to go through withdrawal. People think of somebody's going to detox, and that lasts, days to weeks, depending on the acute withdrawal, depending on the drug and the person and such. And then I always talk to people about post-acute withdrawal syndrome. And this is something where, as the brain is healing for like 2 years, and what the literature says, and I would always tell people this, the literature says that you can have these, and what post-acute withdrawal syndrome is you're feeling great, but then after a few months, you just have all these symptoms come on for a few days, and then you're feeling great, and then about 6 months later, and it can last up to 2 years. But I've seen in the years at Hanley, there have been cases where people have said to me year after year after year, we have an alumni who still comes back. She went through care maybe 18 years ago and still comes back and helps people to this day. And all these years later is still saying, I still have some of those symptoms. And the only time I've ever seen it is with benzodiazepines. And now, up to now, when I would talk about it, and I would say, guys, this is what the literature says. This is what post-acute withdrawal is. And I can tell you that sometimes I see something different. And Dee, you and American Society of Addiction Medicine and researchers, and y'all have put a name to it. Can you tell us a little bit about it and how you get through it?
Yeah, let me differentiate real quickly on the Bind paper. Was one of the papers that we published. We published 3 papers on the benzodiazepine survey of 2018, 2019. That third paper was the Bind paper. That's where, and there was a nosology team. So we got together 23, 24 experts, doctors, lived experience that determined the name based on the research we had done. As a statistician for the team, because I had the database experience, that's one of the reasons I got into the research. So there's the answer to maybe one of your questions. I ran these numbers and I started to see this thing jump out. And what happened was we had this acute withdrawal period, and the short-term symptoms from people coming off of long-term benzodiazepine use were typically whole body tremors, hallucinations, seizures, these really severe, strong ones. But they rarely lasted outside of 30 days. That's typical acute withdrawal. We've seen that in other drugs. We see that, you've probably seen that too with, heroin, opioids. We see that with other drugs. This was different. Then we saw this other group of symptoms, okay? And they typically were months out, years out. And they were a totally different subset. They didn't usually happen immediately. They happened over time. That's where we started to see what we call bind. And so we saw something that I brought that to the research team, the data, and Dr. Peter Martin out of Vanderbilt, and Dr. Reed Finlayson over there, and Dr. Alexis Ridfo over at CU. All the doctors got together. And I remember Peter Martin, because he was there and he said, that's neurotoxicity, that's neuroadaptation. He just jumped on it because he knew what he was seeing. And I didn't have that knowledge. So he came in and he said, I know what we're seeing. And he got all excited. And that's where the whole paper came with bind. Was we'd had all these other terms, like you mentioned, PAUSE, which is post-acute withdrawal syndrome, protracted withdrawal, so that we'd seen the signs, but we didn't have a name to really put to it. There was a lot of confusion. And so our goal with that paper was to say, hey, this is what this is. Let's identify it. This is what we've seen. We now can actually see in the data how this is different. And this is a different condition. It's neurological adaptation. It's neurological toxicity. It's what's happening, neurologic toxicity that's happened to the body. You mentioned ASAMS, the American Society of Addiction Medicine. I got pulled into that to be on the lived experience panel. So we had 2 different panels. We had the doctors who were writing up all the initial, this was the de-prescribing guidelines for benzodiazepines. So the tapering guidelines. And they were working those off at the lived experience panel. We got to meet with the doctors initially, and then we would write back, go back and forth. I am very grateful to say to ASAM that they took a lot of our notes and they used a lot of it. This document's not perfect by any means, and we still have a lot of things we would like to change in it, but it was a huge step forward, and it was the first clinical guidelines ever produced for doctors that identified the long-term damage benzodiazepines can do. And
That's huge.
yeah, and they mentioned bind in it and everything else, but I just want to thank ASAM because ASAM did this research, all funded by the FDA, and it's really made a big change, and we're starting to feed out. There were 10 different medical associations that signed on to this. So yeah, go ahead.
You mentioned that your taper was 18 months.
Yeah,
Talk a little bit more about that for our listeners. I think that anybody who caught that at the beginning likely would be confused because people come into Hanley and they think a detox period or a landing period is 3 to 5 days, and that's somewhere out there on the internet. People don't realize that there are so many different factors that go into any individual's care. So,
absolutely. And I think that's a significant point. Um, Benzodiazepines, unfortunately, for some people, and I do want to say for some, because this is not a guarantee. There are people that just stop taking a benzo cold turkey and have no issues. Okay. The problem is we don't know who those people are. So we never advise anybody to just stop taking a benzodiazepine. It actually can kill you.
Yeah,
Okay.
I just want to reemphasize that,
Yep.
that
yeah.
that's be clear. If you are
Yep.
on benzodiazepines, do not stop without talking to your doctor.
Exactly.
Yes, absolutely.
Yeah. In fact, it and alcohol, and I think there's one other now, but alcohol and benzodiazepines are the only two drugs that can be lethal when cold turkeyed.
And thanks
So
for mentioning alcohol. People don't
you
realize.
betcha.
People
I
think
know.
I can go cold turkey. And I mean, it is, you know,
Central nervous system depressants
yeah.
are
Yep.
barbiturates of the other category are just they can kill you. The
Yeah.
Yeah.
detox can.
Exactly.
Go on.
And most people don't realize that actually benzodiazepines are closer to alcohol than almost
Right.
any other medication. Okay, they're both
Right.
sedatives. They're both sedative class of medication. So there's a lot of crossover, same GABA A receptors, same things in the body it affects. And so that makes sense for why that is. But anyway, one of the things I want to mention is, so we always recommend slow tapering. We always recommend coming off the drug slowly. Okay, and that's one of the things we emphasize. Thankfully, when I found out, I had a doctor who prescribed me the drug 12 years ago. Had relocated, was going to a new doctor, and she prescribed me Prozac. And I didn't know why she prescribed me Prozac. She goes, well, that's to help you come off the Klonopin. Why am I coming off the Klonopin? I never looked it up. That was on me. I never even looked up this drug to know what was happening. The night I looked it up was the night I had my first all-out panic attack. I went downhill from that fast. I was intolerant. I was dealing with symptoms. I didn't know these symptoms came from the medication that I was dealing with. So thankfully, I went to a different doctor who actually didn't believe I needed to come off the drug, but was old school and he was willing to work with me. And he said, whatever you need, though, I'll work. But he wanted me to wait 6 months. So I waited 6 months. Then I started to taper. Over 18 months, I came off the drug. I directly tapered off Klonopin. There are many ways to taper off. There are substitution protocols. There's micro tapering. There's all kinds of weighing and things. It gets complicated when you think about it. But I came off the drug over 18 months. And I jumped off of a 1/4 milligram of Klonopin. Clonazepam is the generic name. The problem with this, and something important to keep in mind for people, is that not all benzodiazepines have the same potency. Okay. Halcyon, Xanax, and Klonopin are generally 20 times as potent as Valium. And so jumping off a 1/4 milligram is jumping off of 5 milligrams of Valium, which is a big number. So I did that, had a lot of complications. I did other things wrong. I had a real hard time for about 2 or 3 years of severe symptoms. Very, very disabling type of experience, extreme. I gotten better. I'm doing better now, and I'm doing much better, but I still have symptoms. I still have limitations. I still have akathisia, tinnitus, muscle pulls. I have cognitive dysfunction. I have memory loss. I have all kinds. I could just go on and on about things that still stick with me. But the good news is I'm doing better. And one thing I want to make sure I always emphasize is that this is a frightening condition. And I want to let people know that with help and with guidance, people come off benzodiazepines safely. Okay, most people do okay. It's not a picnic, but if you do it right, you slowly taper, you work with the doctor, you work with other people who can counsel you through it. There is most thousands of people come off these drugs every day. Okay, it's just you got to make sure you do it right.
And what's for someone who's out there and they're on their, they and they say, well, why should I? What's the benefit of coming off? Why come off?
Great question. Yeah, because and we get that a lot. And number one, the first thing I want to say, and this is I'm not speaking for other people in our community, but what I'm saying is usually repeated by most of the people in our community because we all work together and everything. But with these medications, one thing is we never want to force anybody to come off these drugs. Okay, nobody should be forced. It's a hard thing to do anyway, and you need the buy-in. It's just like saying, forcing somebody to do the rehab, forcing somebody to do other things. You're not going to get the results if, so we don't think anybody should be forced. But we believe you should be encouraged to come off the medication strongly because there are long-term consequences. We don't really know the ties medically through research of duration on the drug or dosage and how that affects the likelihood of buying or protracted symptoms. We don't really have that, but we do believe that there are factors there. So the longer on the drug, the more you are changing your central nervous system and your peripheral nervous system, and then the harder it may be to come off this drug later. And at some point, you might reach tolerance. That drug is no longer helping you. You're getting symptoms and you're going to have to come off. And so that's the main reason why we encourage people to come off the drug because it's altering your central nervous system right now as you're taking it. So the longer you do that, then, the harder it's going to be.
I think about canoeing. I live in Florida, and we love canoeing. And I think about going with the current. And
With
I've
the
got
current,
I've got to
yeah.
be back tonight, but I'm just going to go over. But the further I go, reality is the harder it's going to be
Yeah.
going back the other way. I don't know. That was just a picture that came in my mind.
Mhm. Exactly.
So one of the things that I would find when I would talk to people who had, symptoms over a long, well beyond a year or 2 years or 3 years, one of the things that they would say is, man, people just didn't believe me. People thought it would tell me it's in my head. People would tell me, have you experienced that? Is that something that, because it would seem to me that having now this having an understanding of mind and what it is and being able to put a name to it, I wonder if that will help with that stigmatizing
Absolutely.
attitude.
Yeah, let me say one thing first. It's such a pleasure to have somebody who actually has looked into this and understands these drugs because you're asking all the right questions. And I can tell you've done your homework. And I just want to say thank you for that because these are great questions to ask.
Thank you.
Yeah, as far as those complications, as far as what happens with the drugs, and I'm gonna can I say one thing here? One of the podcast episodes I heard you listen to, you mispronounced somebody's name. It was something Zlan or what I don't know. It was one recently you did, and then you said, "No, we're just going to leave it in because this is who we are, and we're going to allow things." And I do that on my podcast all the time. I want to tell you just right now. Could you re-ask the question?
Yes.
And the reason I'm saying this is one of my symptoms.
Yes.
Okay, my short-term memory and my cognitive decline. I can lose something in 5 seconds. That without notes, and I actually even have been writing down some things that you talk about, so I know I can go back to it. But I have trouble hanging on to things that long, and that's actually part of my mind.
Thank you
And
so much
so,
for being a
you bet.
human being, man.
Thanks.
I
For
can't
being
tell you how
vulnerable.
much I appreciate that. And I know that other people do because we all find ourselves there. And I just respect the heck out of you do. So let's see if I can remember the question because
Yeah, the question is, can you remember
I
the
just
question?
naturally, but no, I was thinking, and this particular one wasn't even about research. I'm thinking about a particular person, that person who went through treatment many, many years ago and still comes back. And one of the things that she would say is at some point, she says, if I don't even tell people about what I'm struggling with anymore because they don't believe me. They think the pain or the fog, they think it's all in my mind. And how do you deal with that? And what message do we give to people who might think it's just all in your mind?
Several presentations I've given in the past and that we've done a subtitle on it called The Hidden Epidemic. So benzodiazepines, the hidden epidemic for this reason. And it's because it is not known. Most medical professionals, I do some CME trainings with different doctors as we're trying to get the word out about what's happening, but most are educated that there is an acute withdrawal period and it can last up to 2 to 4 weeks, as the medication is finally removed from the body. After that, they don't have it. We actually just finished a study. We published this two weeks ago. Just came out. It's the largest scoping review of benzodiazepine protracted symptomatology ever done. We started with over 11,000 studies, and we just got this published. So in that, one of the key problems we found some data, but over 11,000, we found 46 studies that we could actually look at. That was it, out of 11,000 originally captured. And one of the reasons being is that doctors were not looking for. Two key things we want with the studies is one, very rarely do they ever look past 30 days, especially past 3 months, even 6 months. They don't look that far out because they don't believe there's anything there. They're looking for complications immediately coming off the drug. And so that's one of the key problems. The second is they don't even know what symptoms to look for because nobody really had identified the protracted symptoms, what we now call bind. These are different than those hallucinations, those tremors, those seizures, those other things you see originally. These are different symptoms. And so they weren't looking for it. So that's to explain one of the problems is one of the key issues the people who we work with come to us is lack of support from their doctors. They're dismissed, they're disbelieved. It's just really difficult for them to find any support.
This is you're talking about stigma, obviously, as well, even with physicians. There was an article sometime in the last decade about a very, very well-known female singer
Okay.
who was coming
Yes.
off of the drugs
I
and
believe I know who you're talking about. Yes.
yeah, uh, for the first time was really talking about this, you know, widely and broadly, so that people were able to hear and understand what her experience was. I believe she was on the drugs for more than a decade, and then tried to come off, and essentially had exactly what you were talking about for many, many years afterwards. It takes somebody like you or somebody like her speaking up about their lived experience for people to understand, first of all, I'm not alone. And number two, it's okay to put up your hand and ask for help.
Right.
Yeah. Yeah. And it's really been hard. One of the things often patients will ask me, and we've developed this, is what documentation can I take to my doctor? And in fact, I was coaching with a client yesterday, and that's one of the things I posted in there because this person wanted to take that to their doctor to be able to show their doctor, hey, this just came out from ASAM. This just came out from the FDA in 2020. Here's what the public health organizations are saying about this. So it is real. Please read this. And it makes a difference. It really makes a difference. I've had the pleasure of working with doctors over the past who I've tried to tell what I'm going through and they didn't believe me. Over time, they started to believe me. And now what's nice is I kind of have this icebreaker. I walk in and say, I'm a medical researcher with benzodiazepines, and boom, I'm suddenly a colleague.
Right.
It's like, I
That's
have that benefit. It's like, but
The
my patients that I
credibility.
work with don't have that benefit, you know?
well, speaking of benefit,
Ugh.
I wish that I would actually like to do a part two.
Yeah, I would
I think
too.
there's more
I
to
would
this,
too.
but
Love that.
I'm the bad guy and we have
It's okay.
to wrap up. But if you've watched, you know that we're always interested in letting you have the last word. And I wonder if you might have two today. I wonder if you might have one thing that you would say to those who might be struggling or suffering with, you know, wanting to come off benzos or even maybe they have. What would you say to that struggling person? And then also, do you have something that you would say to friends and family members and others who are around them who might be struggling with figuring out what's
Yeah.
going on?
I'd be happy to. I'm going to start with the second one. This is from my memory. I'm going to start with the second one, and that is the number one thing. My wife actually wrote a chapter in my book for the caregiver of how to handle work with people going through this. And one of the things she said above all else is believe them. And that's the best thing you can do, is believe them. Believe that what they're going through is real, because they're not getting that elsewhere for so many of these people. That's the number one thing I would say for somebody around this, is just validate that what they're going through is real. For individuals that find themselves in this position, my number one thing is you can get through this, and you can do this, and you can survive. There are thousands of people like me, and I can refer you to them. Just come check us out. I'm happy to send you anywhere you need to go. There are coaches that are incredible. There are communities that are incredible. There's associations that are incredible. We have 100 times more out there than when I started on this 13 years ago. So there is so much support. Yes, it's daunting. Yes, it's frightening. Yes, it's scary to go through this, but we have a community of individuals that can help you through it.
Love
I
it.
couldn't just say about it. Thank you so much for your
Thank
time. It
you.
has been fantastic
It
meeting you. I
has.
look forward to talking to you again. I
I've
know it's
loved
going to
this.
happen. And, Dr. D, thank you as well. This has been super fun as always.
Thank you, Dr. D.
And for all you watching or listening, thank you for being here. And we'll see you next time on The Hanley Effect.
Bye, everyone.
Thank you for joining us for the Hanley Effect. To learn more about our programs, visit hanleyfoundation.org or call 844-502-4673.